Welcome to CME on ReachMD. This episode is part of our Minute CE curriculum. Prior to beginning the activity, please be sure to review the faculty and commercial support disclosure statements, as well as the learning objectives.
This is CME on ReachMD, and I'm Dr. Karin Blakemore, and with me today is Dr. Emilie Vander. Dr. Vander, once we've made a diagnosis of FNAIT, what are the treatment strategies, particularly for future pregnancies?
Thank you, Dr. Blakemore. Currently, there is really no national or international consensus on management of affected pregnancies, and treatment strategies do vary depending on local practices. Moreover, treatment varies depending on timing of diagnosis, with management strategies varying when diagnosed during the fetal or the neonatal period. As we mentioned previously, neonatal treatment for infants suspected to have FNAIT mainly hinges on platelet transfusion. However, IVIG and steroids have been used as well. Most importantly, treatment of a newborn with severe thrombocytopenia often begins before diagnostic test results confirm FNAIT in order to avoid the risk of severe complications such as intracranial hemorrhage. Historically, FNAIT was diagnosed antenatally via percutaneous umbilical blood sampling, or PUBS, and early treatments for these pregnancies included intrauterine platelet transfusions, similar to the fetal red cell transfusions performed for HDFN. Current treatments also, in some practices, will include this. Other places have moved away from this because of risks of PUBS and or loss of that skill, as it's a very specialized skill to perform, and certain institutions don't have that ability. Currently, other than PUBS, the mainstay for treatment of FNAIT during pregnancy is the use of weekly maternal infusions of IVIG, which is thought to block the neonatal FC receptor, or FcRn, preventing maternal antibodies from crossing the placenta and destroying fetal platelets. This is used usually in conjunction with the addition of oral steroids, typically prednisone, to further suppress the maternal immune system. Timing and dosage of these treatments is dependent on severity of FNAIT in a prior pregnancy, with women who have had more severe FNAIT or earlier instances of fetal ICH typically requiring earlier treatment and higher doses of medications than those with more mild cases. Pregnancies affected by FNAIT are also recommended to undergo either early term or term delivery, and then management strategies in terms of mode of delivery vary by institution and by case-by-case basis.
The use of fetal blood sampling is actually something that we still offer all of our patients. We also start our IVIG virtually always at 12 weeks. The platelet antigens are already presenting their little cells certainly by 16 weeks and to the mother. So the mother's going to be making antibodies that are going to start destroying the fetal platelets to some extent anyway, long before 20 weeks. So we start everybody at 12 weeks, and we actually do a fetal blood sampling, usually just once at about 34 weeks, at which time we know what the fetal platelet count is. And most of the time, 80%, 90% of the time, the fetal platelet count is very adequate. At which time we talk to the patient and, yes, in a shared decision-making, decide when to deliver. We virtually always go vaginally, but that's virtually because the platelet count is almost always good when we've used this weekly IVIG therapy. This weekly maternal IVIG is a tough thing for those women to go through, but the problem is if you start it later, you sometimes are behind the 8 ball by the time the 20 weeks rolls around, say, when you're starting IVIG that late.
That's a great point. I think there were other treatments available for patients that didn't have these significant side effect profiles. Long-term patients may tolerate things better.
Well, thanks. I think our time is up, and thanks for this discussion.
You have been listening to CME on ReachMD. This activity is provided by Omnia Education and is part of our Minute CE curriculum. To receive your free CME credit or to download this activity, go to reachmd.com/CME. Thank you for listening.